So I was asked to speak about Parkinson's disease, and I kind of deviated a little bit from what Ian asked me to talk about. Ian asked me to talk about making a diagnosis of Parkinson's versus non-Parkinson's, et cetera, and I do think that is an interesting talk that we could have at some point. But I think more importantly is just knowing something about Parkinson's in all its protean manifestations and how to tackle some of the different symptoms thereof. The downfall of giving that as a topic is that it can sort of turn into a bit of a list, and so that's again why I think if you have some points you want to stop me and interrupt me, and if you think, oh, that reminds me of a patient I saw yesterday and I didn't know what to do with them, then you can let me ask me some questions and we can go with that. So I do have to mention my disclosures. I'm participating or have participated in clinical trials with these sponsors, mostly related to Alzheimer's disease and frontotemporal dementia, so they're not really related to Parkinson's, so I don't think there's much conflict there. I am on the board of directors of Headway, which is the Victoria Epilepsy and Parkinson's Center, and I do think maybe that's a bit of a conflict in one way, in that I think that without them, many of our patients who are still at home and not in residential care would not be doing as well. So a little plug for that organization that runs on a shoestring for those of you who are still seeing outpatients who have epilepsy and Parkinson's. They really do a good job. And I will be discussing off-label use of various medications, but again, none of which that I have any particular interests with. So by the end of the presentation, I'm hoping that you can describe the estimated prevalence of Parkinson's in the residential setting. Ian, sorry, you don't know how to actually turn on the monitor there, so I don't have to keep craning my neck, eh? List the symptoms of Parkinson's disease and give you a little bit of an approach to a systematic approach for evaluating your patients with Parkinson's. And again, the format's supposed to be sort of me blabbering on for 45 minutes and Q&A, but feel free to jump in. So in the US, we, as with many things, we don't necessarily have good numbers for Canada, but often we can extrapolate Canadian situation from the American situation, but with the big caveat that our healthcare systems are run quite differently. But in the US, 25% of patients who have a diagnosis of Parkinson's disease prevalent reside in long-term care facilities. So that's a pretty big number. And of those patients, only a third of them still have any contact with outpatient neurology, and that contact may be once every 18 months going for a bit of a check-in. So the lion's share of the management of complex end-stage Parkinson's disease is actually done by primary care physicians. If you have Parkinson's disease and you have dementia, or you have Parkinson's disease and you fall and you break your hip, then that dramatically increases the chances that you're going to be in long-term care, and I'm sure that's not surprising to anyone here. If you look at the flip side and look at all your patients that you care for in residential care, at least if you're in the United States, up to 10% of those patients may have a diagnosis of Parkinson's disease based on some epidemiological studies here. So a prevalent condition in residential care for sure. Okay. So what is Parkinson's disease? I will refer you to this great review paper by Kalia and Lang from the Lancet about 18 months ago. There's not a tremendous amount that's changed from that time, and this has the benefit of being a very well articulated and easy to read paper, where they explain all of the different ways that we've learned that our neurons break down in this process called Parkinson's disease. And a lot of that information has been gained by studying patients who have genetically inherited forms of Parkinson's disease and trying to figure out what those genes do, as well as susceptibility genes. And the take-home point of the slide is just to show you how incredibly complex the pathophysiology of this disease appears to be. And this is really only at the level of the neuron once the disease has started. So if you go back and ask the question, how does the disease start in the first place, that appears to be extremely complex as well. Some very exciting but puzzling evidence coming out showing that it may actually be in some forms an acquired disease, maybe related to our gut microbiota, and that Parkinson's disease can spread prion-like from cell to cell if you do carefully constructed experiments. So complex illness that we don't know very much about. But If you go and look at the textbooks, the hallmarks are a loss of dopaminergic neurons in the substantia nigra pars compacta. And what I'd highlight of that is that is really the lesion that's responsible for the most obvious early symptom of the disease, which is the motor symptoms of the disease. And so that's why we traditionally focus on this one little area of the brain, but as I'll talk about, there are many other areas that are affected. And the other hallmarks are depositions of these Lewy bodies, again, in these substantia nigra neurons, but also in other parts of the brain as we're going along. So the symptoms of Parkinson's disease, as you probably know, the motor symptoms, this tremor, rigidity, akinesia, and gait impairment. I think most people here know that quite well. But if we think about the extramotor symptoms of Parkinson's disease, I don't know if all of us could always list these off quite easily. And so I kind of like to think about these as there's a whole group of somatic non-motor symptoms of Parkinson's disease. So sleep disturbances, especially REM behavior disorder. Anyone not familiar with REM behavior disorder? REM behavior disorder is when the patient's spouse tells you that they've actually had to move out of the room because they keep thrashing about and trying to jump on them in the middle of the night and stab them and punch a hole through the wall. That's at its most extreme. But sometimes actually these patients will have had this as a very early manifestation of their illness, 10, 15 years before any other symptoms show up, and they've never been asked about it, and so they've never mentioned it. Olfactory dysfunction happens very early on and is a reliable symptom. If you look for it, all your patients with Parkinson's can't really taste their food very well anymore and will complain of at least a decreased smell sensation. Visual disturbances, quite common of various types. Constipation, excessive daytime somnolence, dysphagia, autonomic dysfunction, especially orthostatic hypotension, but also urinary autonomic symptoms, sialorrhea, hyperhidrosis. Neuropathic pain, central neuropathic pain from the disease, and appetite and weight changes, which can sometimes be very profound. And again, we heard about hip fractures, so if your patients are wasting away in front of you and then they fall and break their hips, it doesn't help. And these can all be actually much more severe than the tremor, rigidity, akinesia, and gait impairment, and sometimes can be the main issues that are bothering the patient much more than the tremor, even though for 10 years they've been seeing a neurologist who's been fiddling with their medication to help with their tremor. What's actually bothering them is their constipation or their dysphagia or their pain, for example. And then we talk about the neuropsychiatric symptoms, so cognitive dysfunction and frank outright dementia, hallucinations, anxiety, depression, apathy, delusions, and impulse control disorders such as pathologic gambling or hypersexuality. So how many people thought that these were all symptoms? People looked at this list and said, yeah, this is Parkinson's, or is anybody surprised at the size of the list here? So it's complex, and there's a lot of issues to think about when you see the patient who has a diagnosis of Parkinson's. And conversely, when you see that there's a patient who has Parkinson's and has anxiety, you may recognize, for example, that that's a symptom of their disease and may require a management approach that may be a little bit different than run-of-the-mill anxiety that someone who doesn't have Parkinson's will have, for example. This is again from that same review article I talked to you about earlier, and shows the general trajectory of progression of symptoms of the disease. And so the one thing that Dr. Lang and his colleagues are highlighting here is that many of the somatic non-motor symptoms of the illness actually predate the motor symptoms by many years. Constipation can show up as early as 20 years prior to the illness, and it's interesting if you take a history back to your patients and say, oh yeah, you know, they notice their bowel patterns changing in their 50s, but they never really clued in that was something that they should tell you about. The REM behavior disorder I talked about, the changes in smell, and some early changes in mood may predate the onset of, I think there's even a pointer here, may even predate the onset of some of the motor symptoms. And then the motor symptoms pick up and the neuropsychiatric symptoms pick up. The other thing that this graph highlights is that some of the neuropsychiatric symptoms are actually complications of the treatments of the illness. So sometimes some of these neuropsychiatric symptoms can be symptoms outright of the disease, but sometimes they're a complication of the treatments that you're giving. And part of the skill required to manage these patients is trying to untangle that issue. We'll talk about that a little bit. I won't show too many brain slides, I promise. But this is actually a really fundamentally important thing to understand about this disease, is that it appears that statistically speaking, there's a fairly orderly progression of how the disease spreads throughout the brain. And again, I spoke to you that we're now seeing that there can be direct cell-to-cell transmission of what seems to be some sort of infectious principle behind Parkinson's. And so very often in patients who go to autopsy, the changes of Parkinson's in the very early stages will be seen mainly in the olfactory bulb, therefore the smell changes, and in areas of the brainstem that involve sleep, for example, so therefore the REM behavior changes. In middle stages, pathologically, this spreads up to other areas of the brainstem, and therefore you have those motor symptoms that I've said have been heavily focused on because of this area in the brainstem called the substantia nigra over here. And then as the disease progresses further, you have further spread of the Lewy body pathology throughout wide areas of the cortex, leading to many of the other disturbances, particularly the neuropsychiatric symptoms. And again, if you look at autopsy studies in a big group, you can see, statistically speaking, this kind of orderly progression of the pathological changes that explains the progression of symptoms as the disease progresses. So as I mentioned, Parkinson's is a very protean illness, and some patients will complain mainly of the motor symptoms, and they may actually be adequately treated for years. And other patients may have non-motor symptoms quite early on in their illness, and it may be quite debilitating, and the psychiatric symptoms may show up quite early, within 2-3 years of the onset of disease. And so the take-home to that is, don't ever think that two patients with Parkinson's disease are really alike. The experience you had with the one patient you just saw is going to be completely different with the next that you see. So, question here, what are some of the challenges that you have had in treating the motor symptoms of Parkinson's disease? So just bringing it to the parts that people normally traditionally associate with treating Parkinson's disease. Just yell out some thoughts, challenges.
They fall all the time.
Falls. So patients fall all the time. Well, how do you treat their falls? Anything else?
Postural hypotension from treatment.
Okay, hypotension. And again, traditionally speaking, that won't be considered a motor symptom, but certainly an important symptom. We will talk about that in a couple minutes.
Dyskinesia, difficulty of swallowing.
So difficulty swallowing again. So it's interesting, because if I had given this talk 6 or 7 years ago, people wouldn't have been mentioning some of these symptoms as much. So I think people are more clued in now that these non-motor issues are really circling around Parkinson's. The speech.
The voice can become more and more, lack of volume.
Yeah, so difficult to understand the speech. Yeah. Are there motor issues?
The freezing.
Freezing, so freezing is an important one. And that's often associated with the falls, but sometimes they're quite separate. Any other issues?
Uncoordinated movements, like they couldn't feed themselves.
Okay, so difficulty, and we talk about the different types of uncoordinated movements.
It's important for them to have their meds on at the right time a lot of times.
Okay. And what are some of the things you experience when they don't get their meds on time?
Freeze, or they might have too much movement, so they might not be able to feed themselves, or other mobility ADLs.
So brittle changes in their symptoms from hour to hour, and especially depending on the medications. Yeah. So the treatment of the motor symptoms, many physicians are familiar with. The mainstay is this medication levodopa, which is converted to dopamine in the brain, and this area that I mentioned, the substantia nigra, synthesizes dopamine, and so the idea here is if those cells are dying, we just give the dopamine back. It's given with another agent, either carbidopa or benserazide, depending on which drug you have, which blocks the peripheral actions of the levodopa in an effort to try to reduce the peripheral side effects. The other mainstay are dopamine agonists, so these are synthetic molecules that directly act on the dopamine receptors, and the ones you will see most often are pramipexole, ropinirole, and the rotigotine patch. Bromocriptine is still used, but much less so than it previously was because it has adverse effects, especially patients who are given rotigotine for an extended period of time are at much higher risk of pulmonary fibrosis and heart valve problems. Other agents that you will increasingly be seeing are MAO-B inhibitors, especially rasagiline. So MAO-B is one of the enzymes responsible for the degradation of dopamine, so that keeps the dopamine around a little bit longer. And COMT inhibitors, entacapone. So again, COMT is the other metabolic pathway that goes to degrade dopamine. Anticholinergic agents, especially trihexylphenidil, used to be quite popular, and there still are some patients on those. They have, by definition, anticholinergic side effects, and so they've largely fallen out of favor, but some patients are still on them. And amantadine, which is actually a medication that acts on the NMDA system. So is there a question in the back or a stretch? Where do you start? When? So my suspicion is that many of the patients in residential care have already started, but when I see patients earlier on in the course of the illness, there's kind of two decision points to me. There's the one type of patient who is minimizing their symptoms, and I can see that they have enough hesitation in their gait, enough slowness of their movements that it's likely impeding them functionally, and those are the patients I try to convince and say, why don't you have a trial of this and see whether a month from now you come back and you say, oh my God, I can play golf again, right? And then there's the other group of patients who are keenly aware of their symptoms and have very, very minimal symptoms, and then we just say, well, we're going to start this when it actually seems to be severe enough that it might limit your function. So I think that's the key, is whether you're getting a sense that there's any sort of functional impairment that's significant enough to be worth, and that's really a judgment call. So in the residential care setting, the challenge is that many of the patients have comorbid psychiatric or other symptoms that are actually aggravated by some of these medications, and so that becomes quite challenging. And the biggest example is orthostatic hypotension, which is a symptom of the disease itself, but is actually worsened by the peripheral action of dopamine rather than improved by it. Another one is psychosis, which again is a symptom of the disease, particularly as the disease advances, and again is worsened by dopamine rather than improved by it. So if you have your patient with Parkinson's who has had enough of their disease career with this, that they're now starting to have some psychosis, starting to have orthostatic hypotension, what do? So the principle is that you try to reduce the medications, the dopaminergic medication, trying to compromise their motor function as little as possible. And really the take-home message here is go very slowly and reassess as frequently as possible. Okay? So I do see people who say, well, we're just going to chop their doses down by 50%, and I'm not sure that I would advocate for such a dramatic thing unless they're completely psychotic and having to be in 4-point restraints or something like that. Because you want to see, they got up to that dose for a reason, because they were getting some motor benefit out of it. So you really want to try to reduce it as slowly as possible so that you can see what's the lowest dose I can get with to still have some benefit. And this is again the idea that you want to check back on them a week later or 2 weeks later and see what the effects of your treatment have been, and then keep going with your strategy if you seem to be headed in the right direction. The dopamine agonists are used to minimize the levodopa-related fluctuations. So we heard briefly about those dyskinetic movements, and that's the major complication of levodopa, is when you get to a point where your sweet spot of the levodopa dose that your brain wants to sense is quite small, your brain's going to be spending some time with too much levodopa on board, and that causes dyskinetic movements. That's a very simplistic explanation of it, but it's a good way of thinking of it as a framework. So when patients start to develop dyskinesias, they may be weaned off of levodopa partially and put on dopamine agonists, or if they're young enough when they start their Parkinson's disease, their treating physician may choose to start them on a dopamine agonist at the beginning to try to reduce the risk of them developing dyskinesias. But generally, they're less effective in terms of bang for your buck per dose of medication, how much they're going to affect the tremor, how much they're going to affect the rigidity. So if you have a patient who's on both levodopa and a dopamine agonist, I would start by reducing the dopamine agonist before touching the levodopa. And as I mentioned, you're going to have some patients still who have been started on an anticholinergic, and they will all worsen their cognition and cause urinary retention and all those things. So if they're on an anticholinergic, then I would definitely start by reducing the anticholinergic. Amantadine is a medication that's actually most often used to treat dyskinesia, so those writhing movements. And but amantadine has anticholinergic properties. So if you have your Parkinson's patient who's become confused now, again, before reducing the levodopa, I would maybe see if I can reduce the amantadine, which is probably giving them the least overall benefit for their movement symptoms. So what types of motor fluctuations exist in patients with Parkinson's? Well, that's a question for you. On-off. We kind of mentioned all of these already. On-off. We mentioned the dyskinesias. We mentioned freezing. And freezing can happen both in predictable ways and unpredictable ways. And dyskinesias can also happen in both predictable and unpredictable ways.
The pain is not always constant.
Pain is not always constant either. And again, pain, when we kind of think of our framework, we normally think of as a non-motor issue, but it often overlaps with this as well. Whoops. So wearing off, to go to Dr. Rosenberg's point of on-off, you can have patients who have predictable wearing off, and so they take their dose at 9 o'clock, and at 10:15, it's not working anymore. And that's a pretty, when you can document that, then at least you kind of have a better idea that it's really clearly the medication that's wearing off. More troublesome is the unpredictable wearing off, where all of a sudden, bang, they're off. Or this phenomenon called the missed dose, where every once in a while, even though they take their medication, their body doesn't see it for some reason, and it's as if they hadn't taken it. So for the end of dose wearing off, then often the strategy will be to try to take their total dose and redistribute it so that they're getting it more frequently, and especially if you can get that clear timing, then it's easy. You can add an MAO-B inhibitor such as rasagiline, but again, in the residential care setting, when many of our patients are dealing with polypharmacy, it may not be such a practical tool because it has a lot of drug interactions. And you can add the COMT inhibitor and entacapone that I talked about. You may need to reduce the levodopa dose because in addition to extending the life of the levodopa, it kind of extends its efficacy. And diarrhea is a common side effect, but it's actually quite often a useful tool when patients are wearing off. For the unpredictable or the missed dose phenomena, first thing you can do is make sure that they're not having high protein loads at the same time as their levodopa, so you can sometimes space out the timing of their medication so that they're taking it away from mealtime, for example. And you can use a pill in a pocket or rescue dose of levodopa, so if they get a really sudden off, then they can have an extra PRN dose. And I have a few patients who are in residential care settings, and that's quite useful to them, but it's quite a struggle to get the nursing staff on board with the idea of giving a PRN medication like this, and often there needs to be some teaching about this particular patient, and it's okay, and they know when to ask for the medication. And if you've got really good staff who are willing to crush the pill, if the patient just freezes and they can't even get back to their bed, then sometimes just crushing it and giving them with some soda water will help them absorb it really quickly, and then they'll be back to being able to move again.
All right. Let's check in to see if there's any stories from the audience about terrible freezing. Or any questions about that one-time dose?
Here's the question. It's given with soda water, it absorbs better that way, better than putting it in warm water or whatever?
Yeah.
Okay. And the reason would be just the salt?
No, I think it's actually the CO2.
Okay,
Yeah.
CO2, all right.
Any other difficult patients when it comes to freezing that you've got questions about?
So freezing, as I said, some of your patients will have this freezing, so using the rescue doses can be helpful. And then having a clear nursing plan to avoid falls is kind of important, right? So identifying that for this patient, freezing is an issue, and despite what you may want to do to optimize their management, you may not get around it. And there are many patients who are managed at the Parkinson's Center at UBC who still have freezing and can have quite dramatic freezing. So if that's identified as an issue, you need to put proper safeguards in play so that someone's aware that they might get stuck down the hall in the washroom and need help getting back to their room again. So dyskinesias, again, we talked about these kind of writhing, twisting movements that can sometimes inhibit patients from doing what they'd like to do. So these also come in kind of two flavors. One is unpredictable dyskinesias that will just show up like this, and the other is peak dose, which I mentioned is when your brain is seeing too much of the levodopa. And the peak dose ones are pretty clear. So patient takes their medication at 9, and then at 9:30 they start having dyskinesias, and they're sitting around and twisting for about a half an hour. And then they get a good 30 minutes where they're feeling really good, and then they're off. So that's a typical story you'll hear of somebody who's got advancing stage Parkinson's who is quite susceptible to motor fluctuations. And so for the unpredictable dyskinesias, what you want to do is decrease their total dopaminergic burden. And again, you can try adding this drug amantadine, and if the patients are cognitively intact, it's definitely a useful solution. But if they have cognitive trouble, it will worsen their cognition, and if they don't have cognitive trouble, it could cause some cognitive issues, so it's something to watch quite carefully. And if they're getting the peak dose dyskinesias, again, it's the same as the wearing off. What you want to do is give them doses more frequently, but smaller doses. And there you run into all sorts of logistics. Well, how frequently can we give medication on our unit? And that's a real world problem that doesn't always have an easy solution, unfortunately. And then a really important question is, when you're seeing these kinds of fluctuations, are they really motor fluctuations or are they something else? So if the patient is telling you that they're frozen, but no one's actually observed them being in a state of being frozen, and they're sitting there and they're talking and they're animated and they're moving their arms and they're saying, I'm frozen. They're not really frozen, so maybe they're actually anxious. Okay? And now the caveat is, when they are genuinely frozen, they will be anxious almost all the time, because that's a terrible state to find yourself in. But I have had patients who complain of being frozen, and we just keep pumping more levodopa until somebody really does a good 24-hour observation and they realize that what's happening is the patient is having anxiety attacks rather than genuine freezing. And then there may be other types of behavioral issues as well that they're complaining about when they're describing their motor fluctuations. So actually having had someone who's laid a pair of eyes on the patient and describe the symptom outside of the patient's own voice can be very helpful, especially if you're running into a situation where the symptom seems to be refractory to whatever you're trying to do to treat. And so again, in the residential care setting, you kind of need behavioral charting, and sometimes that requires some organization and getting somebody on the nursing team to be willing to spend 24 hours to do some charting of what's happening with that patient, rather than just kind of a little end of the day, you know, everything okay, sign off on the chart. But it's time well spent when you're really trying to figure out what's going on here. All right. So before we move on to this question, actually, any other questions on treatment of the motor symptoms and the fluctuations in particular?
What about patients who have painful dystonias?
Painful dystonia. Most of the time, that's underdosing with levodopa. So often you can improve with increasing their levodopa. So it often will correlate with an off. But there are some patients who have unpredictable painful dystonias. If they're very severe, they may actually be amenable to Botox, and so sometimes that's a really legitimate referral for a physiatrist, or in some centers they're neurologists, but I don't think we have too many. Actually, Dr. Jim Scott will do Botox for dystonia in Victoria, and that's actually an indication that's covered by MSP, so you don't need to worry about that. Those are the two main things. But sometimes think about, is it happening in the context of an off period, because then it will respond to levodopa.
What would be a ceiling dose on the L-DOPA in
Yeah, I don't think there's an actual number, but many people start to top out around the 2 gram range, 2 grams over 24 hours, but that's a very rough ballpark. And really the ceiling dose is when you're starting to come up with too many of the complications. So the patient's having severe uncontrollable orthostasis, or they're getting psychotic. Or the other more challenging situation is when their disease is just advanced to a point that no matter how much dopamine medication you're throwing at it, it's not doing anything. And so there they've reached their ceiling just because they've reached the ceiling of efficacy more than anything else. Yeah. Question in front.
I guess a fairly common scenario is someone with Parkinson's gets a bad infection, like a urinary infection or a chest infection, and doesn't really want to swallow anymore, and doesn't really swallow, and then you get behind on the doses, and then what do you do?
Yeah, so it's challenging. If you're in a setting where you can put an NG tube, it may be worthwhile, and assuming you've discussed, goals of care and you're understanding that it's a temporary NG tube. There are compounding recipes out there for actually compounding rectal levodopa, and every once in a while we've had to do that, and it can be a helpful thing. If it's the pill that they're having trouble, remember that the pill, especially if it's the levodopa carbidopa, can be crushed, so you can crush it with applesauce, and you can even compound a slurry that you can just give them the syrup like you would for pediatric medication. So there are a few options there.
Just wondering how contraindicated is alcohol with Parkinson's?
I don't. There's no major drug-drug interactions between alcohol and the medications that they're taking, and so if the patients are, cognitively intact and they like to have a glass of wine, and the glass of wine isn't then throwing them overboard, I'm not too dogmatic about it, because their quality of life is already hampered pretty big by the illness. Yeah.
Yeah, I was just comment about the CR prep. A lot of people are on this, levodopa, carbidopa CR. And there's two considerations I found in my experience, especially in long-term care setting. Someone is okay on it, but often the mornings are really tough for them. And we almost always put them on fast action as soon as they wake up in the morning, especially for the nursing staff who are doing ADL and their basic care, because it takes a while till it's absorbed. And the other thing I've seen is that some people don't absorb it. You'll see they'll poop it out whole, and there's that, and that may be the missed dose phenomena. For getting people like that, because it's in a wax or something that slowly releases it. So sometimes what I'll do in that situation is just switch up people to the rapid acting.
Yeah, no, absolutely. That's a very important point. I think I actually cut that slide out when I was trying to trim these slides down. But the theory behind a controlled release is a great idea, that it provides this nice, long, extended release and extends the life. But they haven't really gotten there at a chemical perspective, so it's actually quite erratic, the amount that's absorbed and the rate at which it's absorbed. Some patients it works, and if they're on it and it's working, again, I'm not dogmatic about it and I don't switch them, but if I have patients who are running into trouble, then the first thing I do try to do is switch them to immediate release, and then we may have to play around with the timing.
What anticholinergic do you use?
Well, the one that you will see used quite often is Artane or trihexylphenidil. And again, I can't think of the last time I prescribed Artane to anyone, but you will see patients who come in on it.
They're psychotic.
I would take them off it as a first thing, because it is anticholinergic, so for sure it's worsening their cognitive.
Okay.
The most of the patients who are still on it somebody has suggested to them at some point that they should come off it, and they couldn't resist it because they said, well, I was put on this 25 years ago when Dr. Collins saw me in Vancouver, and I want to stay on it now. So.
I just mentioned about the anticholinergics. People get an anticholinergic withdrawal syndrome. I've seen this with Parkinson's, trying to take people off, and their Parkinson's gets worse, and they feel terrible. So it's probably, I would completely try to get people off these drugs, but do it slowly.
Yeah, and again, that first thing I said about going slow, these are all drugs that you want to taper off slowly if you have any choice in the matter. And again, reassessing what you're doing. Yeah. So what are some of the challenges that you've had in treating some of the psychiatric or the neuropsychiatric symptoms of PD in your setting?
Day-to-day variability.
Variability?
Fluctuations are huge.
Fluctuations in?
In the psychiatric symptoms.
In the psychiatric symptoms. So one day they're seeming well, and the next day they're not coherent.
Absolutely.
Yeah. Any other challenges people have experienced?
Hallucinations.
Hallucinations. Big one. Aggression. Often possibly tied to the hallucinations, but sometimes not.
Resistance to care.
Paranoia.
Paranoia. So these are all important issues. So cognitive impairment. We generally talk about two big patterns of cognitive impairment. In Parkinson's disease, there's the subcortical pattern where you have slow thought processing, difficulty with concentration, trouble with executive function. The pathophysiology there is the same as the motor symptoms, so it's a lack of dopaminergic neurons, and so the dopamine feeds parts of the prefrontal cortex that are involved in movement, but also parts that are involved in these kinds of speed of thought processing and executive function. And so the interesting thing is they may fluctuate with the motor function and the treatment. So we heard about, the fluctuation of the symptoms is something that frustrates people. And so the first thing you want to do is check in, and is that fluctuation, is it paralleling any of their other symptoms? Because if it is, then sometimes the clue to the treatment is the clue of treatment of that motor symptom. So every time they're off, their thought processes are slowed and they can't understand what you're saying and they can't concentrate, then maybe actually giving them a bit more dopaminergic medication might help them be on in both the cognitive sense and the motor sense. On the other hand, there's the pattern of cortical cognitive dysfunction, which is really memory dysfunction, visuospatial dysfunction, and that's more due to the widespread distribution of the pathology throughout other parts of the cortex that I showed you there. And that's often associated with accompanied psychosis, so paranoia, hallucinations, etc. And there, very often, the dopaminergic medication will make things potentially worse. But there can also be quite a lot of fluctuation as well, which makes the treatment kind of challenging. Again, a mainstay is look at their anticholinergic burden, try to reduce that if you can. Think about those anticholinergic medications that are on Beer's list and shrink those down. And so here I'm not just talking about their neurological medications, but all of their other meds for everything else that they have. And then cholinesterase inhibitors, there may be a role for them. They've certainly been showed to be statistically effective in Parkinson's disease dementia. Whether they're clinically effective or not, I think depends on who you talk to, really. But I try not to be too dogmatic. If somebody has quite a lot of cognitive dysfunction and a lot of fluctuation and it's causing them to be confused and resisting care, then it is worth maybe giving them a brief trial of a cholinesterase inhibitor to see if it improves things. Some interesting papers have come out very recently about orthostatic hypoperfusion of the brain, and really they gave a bunch of patients cognitive tests to do on a fancy machine where they were lying down and able to do the cognitive tests while lying down and sitting up, and they showed dramatic fluctuations in performance on tests. So if you have patients who are walking around with systolic blood pressures in the 80s, that may actually be playing a role in some of that fluctuation in the cognitive function that you're describing. If you have psychosis, if it's sudden in onset, look for delirium. If it's not sudden in onset, but it's fluctuating, as we've heard, look for triggers. So again, this is where behavioral charting comes in very useful. And then ask yourself, are these symptoms that really need to be treated? And that's an important thing. If they're hallucinations, they may sometimes be benign hallucinations. I wish I had permission to show this video, but I have a great video from one of my colleagues who's interviewing a patient who's describing a whole play that they have outside of their room. There's no theater outside of their room, but they were telling about all the characters that are there, and they're just having a wonderful time watching this play every day. So nobody's going to really jump to give this patient antipsychotics. They're not bothered by it, and in fact, they're finding it quite entertaining. And again, the mainstay here would be to first slowly reduce the dopaminergic burden if you can. Any questions about that?
So I have two, like in previous slide, there was one cognitive dysfunction side, like the subcortical slow thought processing, concentration difficulties. So I was more concerned depression also coexists in Parkinson's disease. So we need to rule out if there is any depression.
Yeah, absolutely. So that's a very important point, is that when you're making this diagnosis of cognitive dysfunction, to look for other things that might be causing this as a symptom profile. And so screening for depression would be a really important thing. Absolutely.
Second one was visual, spatial, and memory dysfunction. There is another variant, you may touch that on Lewy body dementia. So sometimes they can, that can be other variant, when we see visual hallucinations.
Yeah,
and
absolutely.
psychosis.
And I'm going to say something that is probably slightly controversial, but only slightly controversial. I actually think Lewy body dementia and Parkinson's are probably on the same illness continuum. And so the only thing that distinguishes Lewy body dementia from Parkinson's disease dementia is if your dementia is within 1 year of your motor symptoms, it's considered to be Lewy body disease. If you've had motor symptoms for more than a year and then you develop dementia, it's Parkinson's disease dementia. But there are some patients who have this diagnosis of Parkinson's disease dementia who are indistinguishable from patients who have Lewy body dementia 3 or 4 years down the road. So I think many of the principles of treating advanced Parkinson's disease with neuropsychiatric symptoms applies to treating patients who have the diagnostic label of Lewy body dementia.
Is there a preferred antidepressant for Parkinson's patients? I don't know whether this is just me, but I had a few people on Answerin, and for some reason it seemed to help their Parkinson's a little bit, their motor function. So I don't know if dual-acting antidepressants work a bit better. Or?
Yeah, there is. I don't know that that's been formally studied to any great effect, but a lot of people seem to think that, and it's certainly been my experience. A lot of Parkinson's patients who have depression also have quite a lot of the low energy and sort of inertia symptoms that would make you reach for an antidepressant like venlafaxine. I was talking to Dr. Rosenberg just before our talk here tonight, and he was telling me about some interesting things he's learning about some of the risks of our antidepressants. So we always have to be cautious when we jump to prescribe medications. But you will see a lot of patients on an SSRI or an SNRI. I think they're, pardon me, reasonable choices.
One comment about the venlafaxine is it can make a REM sleep disorder worse. So if you take venlafaxine, and they're saying they're up at night and they've got this active nightlife, dreaming vivid dreams and nightmares and kicking their spouse and maybe even getting up, is first thing you should move the venlafaxine to the morning, because a lot of people they take it at nighttime and really they should be taking it in the morning. And then the other thing is to consider taking them off or switching them to a different antidepressant that doesn't affect REM sleep. I don't know if you want to comment.
Yeah, no, that's absolutely true. And actually any antidepressant that has a noradrenergic drive, so patients who are taking tricyclics, even if they're taking a small dose of amitriptyline at night, that can make their REM behavior disorder. So again, unfortunately, the answer is not, there isn't necessarily one size fits all, but certainly if they are depressed and you're confident about that diagnosis, but they have a lack of inertia, then venlafaxine's a reasonable choice. So again, for the treatment of psychosis, you can sometimes consider trying the cholinesterase inhibitor if they have concomitant dementia, and sometimes it does help treat the psychosis without having to reach to an antipsychotic medication. You can consider memantine, although there are several case reports, and I've certainly had personal experience with patients who have a paradoxical response to memantine. So again, if you're going to start them on it, come back a couple days later and see how they're doing. Really important. Of all the antipsychotics, the only one that has some evidence, which is actually quite mixed, is quetiapine. But it's the safest and easiest to use, so it's generally first line. And then clozapine has actually some reasonable, small, randomized controlled trials. But clozapine is a bit of a hassle to use because of the need for frequent monitoring, and it also has a high anticholinergic burden, so you're often treating the psychosis at the expense of possibly making their cognitive dysfunction worse. But if they're floridly paranoid, if they're floridly psychotic, if they're refusing to take all their meds because you're poisoning them, that level of psychosis, then certainly sometimes it is appropriate to reach for the antipsychotic medications, and I would say probably quetiapine first and clozapine if you're comfortable managing that. There's evidence that olanzapine, risperidone, and aripiprazole don't work, so try to avoid those medications in patients with Parkinson's. And I think if you're getting to using these meds, I would probably want or strongly consider that that should be done under the advisement of a geriatric psychiatrist at that point. There is a drug that has come out on the market called Answerin, which is actually a serotonin inverse agonist, and so does not have antidopaminergic effects, and has had quite remarkable effect sizes in clinical trials with none of the antidopaminergic side effects. What is frustrating is the company that makes this drug is a small company who's decided that Canada's too small a market, so I don't think we're going to see this drug anytime soon. But you will have those few astute families who've gone onto the internet and read about it and are coming to you and asking you for this because they can't believe you prescribed Seroquel to their spouse. So just so you know, this is what they're talking about. And unfortunately, I don't think we're going to get it anytime soon. Okay. So before I move on to anxiety, any questions about psychosis at all? Anxiety. So we talked about this briefly already. Episodic anxiety in Parkinson's may or be actually related directly to the motor fluctuations. So again, where behavioral charting and careful observations are important, because if they are, then treating the motor fluctuations will help you treat the anxiety. And so when you are doing the behavioral charting, you need to have enough information to know, well, when the patient said they were off, were they also anxious, and what did it mean that this person observed that they're off? And that's not always an easy thing to get at all. But chronic, non-episodic anxiety is a very common symptom of this disease. So 40% of patients during their illness will develop diagnosable anxiety. And it's interestingly, compared to generalized anxiety disorder, in general, it's less of the ruminative, I'm worried about everything that's happening in the world and in my family kind of anxiety, and it's more this paralytic anxiety that I don't know what to do, I don't know what to say, I just can't get going. So again, if there's concomitant depression, then you can try an SSRI sometimes. If you're going to use benzodiazepines, there is a place for them sometimes if the anxiety is overwhelming and nothing else is working, but use them very judiciously and reassess them frequently and be aware that they increase the risk of falls and confusion. So, and I'm sure I'm preaching to the choir here with this, but sometimes again you'll admit a patient who's on clonazepam 3 times a day, so you have to ask yourself why they're on it, is it still treating their anxiety, and monitor that carefully. Apathy will be different than that paralytic anxiety, where they're not describing a feeling of inner turmoil, but they just don't do anything. And it's very difficult to treat, but this is where, speaking to the point somebody else raised, where making sure that you're not dealing with depression is an important issue. But the patients who are apathetic will actually describe that they don't really have any sort of low mood. In fact, they may be kind of very flat in their affect and just say that they're feeling blah, and they just won't do anything. So sometimes increasing the dopaminergic medication will help. Stimulants can be tried. In my experience, methylphenidate, in the elderly population, I tried to stay away from that medication. Modafinil is used and it's quite expensive. I would imagine, but please correct me if I'm wrong, that in the residential care setting, this is probably one of the least worrisome symptoms that you have to deal with, because if they're apathetic and they're kind of malleable with whatever care you're trying to provide, that's not a bad thing. But it can be quite distressing to families sometimes. I come over and I visit my spouse, and he won't even come to the living room to watch TV with me. So sometimes it's more of a question of psychoeducation rather than trying psychostimulants, so to speak. Insomnia. Every patient with Parkinson's has sleep problems. End of story. They all do. So don't be surprised when you hear about them. So basic sleep hygiene is always the place to start, right? No fluids after supper. Try to avoid the caffeine at night. Make sure they're well established in their routines. They're not sitting up on their iPads at night, etc. If they're having nighttime motor symptoms, so sometimes patients are having trouble sleeping because they're frozen and they can't adjust their bedtime doses, then giving them a dose right before bedtime, and sometimes giving them a dose in the middle of the night can be quite a helpful strategy. If they have urinary symptoms, such as men with a BPH, then treating the urinary symptoms can help. There's limited evidence for melatonin, but many people try it, up to 10 milligrams. And then there's two small trials with doxepin. I used to say 5 to 10. Those trials are actually done with a 3 to 6 milligram dose, and I found out that we finally have the 3 to 6 milligram dose, so you can readjust that to 3 to 6 milligrams of doxepin. Doxepin's an old tricyclic antidepressant. This is quite low doses, but it still does have some anticholinergic properties, so be quite aware of that. And then zopiclone and trazodone are sometimes used as well. Questions about sleep?
Is this an issue that comes up for you? And it's frustrating because
you feel for them, and very often you run through this list and you run through it again, and you don't get very far, unfortunately. REM behavior disorder we touched on already. It may not need treatment, so it may just need an acknowledgement that this is what it is. But if they're putting themselves at risk of harm, if they're thrashing about and they're falling out of bed or hitting things, then it may need treatment. And as we already talked about, antidepressants worsen this symptom. So if this is the symptom you're targeting, then reassess whether the patient really still needs their antidepressant, whether it's at the right time of day, whether it's the right antidepressant for them. Melatonin, again, some evidence for melatonin for REM behavior disorder. And then there is evidence for clonazepam, and it can be effective in some people, but just be aware of that hangover effect the next day. So again, if falls is something you're watching for when you're starting the patients on clonazepam, make sure that you ask for an early morning assessment and that you don't let them fall out of bed first thing in the morning. Okay, how are we doing? Still got a bit of time. So challenges you've had in treating other non-motor symptoms in terms of non-psychiatric symptoms. Anything anybody wanted to bring up?
Sleep disturbance. I found that we had a resident who had Parkinson's, and he would wake up in the night and get very hungry. Just giving him food, letting him sit with us for a little bit, then putting him back to bed, that was helpful.
And that's low-tech intervention. Yeah, a good idea, absolutely. So sometimes not fighting it is actually a really good treatment.
And thinking,
how are they dealing with this symptom at home? Because if that's what they were doing at home, there's no reason to think that you can completely change the routine that they might have built up over the last couple of years and then expect them to have success now. Yeah. Good point.
Do you want to comment a bit about pain management with Parkinson's?
Yeah.
And Parkinson's pain syndromes?
Yeah, we will talk about that very shortly. Yeah. Dysphagia and constipation is the issue. We've already talked about some of these, so I'll just go through them.
Am I going backwards here? Oh, yeah. Okay. So, orthostatic hypotension. As I mentioned, it can be worsened by dopaminergic medication, so consider a slow monitored reduction in their dopaminergic medication. Eliminate antihypertensives if they're on them. That's sometimes overlooked as an easy treatment strategy. Increasing their salt and water intake. And then domperidone, which antagonizes the peripheral action of dopamine, can sometimes be helpful in treating orthostatic hypotension in your PD patients who are on dopaminergic medication. So in somebody who has pure autonomic failure who doesn't have PD, domperidone isn't normally part of the arsenal that you reach to, but in Parkinson's it can be a helpful tool, and particularly if they also have constipation, etc. Be aware that domperidone prolongs the QT interval, and so these patients do need to have EKG to be monitored. This is in the guidelines that you will read, particularly the ones produced by the Parkinson's Society of Canada, to use physostigmine, but I actually personally have no experience with it, so I'm just drawing it to your attention that it is there as something that other people use. And then midodrine and fludrocortisone, which is used for pure autonomic failure, also has a role in patients who have refractory orthostatic hypotension. And so when we're talking orthostatic hypotension, think about the patients who are falling frequently. So your first thing to do if you're dealing with falls should be to ask for frequent sets of orthostatic vitals until you figure out, are they falling because they're having orthostatic fainting spells? Think about your patients with these wild fluctuations in their cognitive dysfunction, and could some of that be due to orthostatic hypotension? And think about those patients who are complaining to you and they're feeling tired and dizzy and weak, and is part of that. If you see a number that fluctuates but they have absolutely no symptoms, then actually ask yourself if they need treatment, particularly if you get below this line here of fairly benign treatments, right? So again, really assessing whether the symptom needs treatment, but if they're symptomatic, it should be looked at. And with fludrocortisone and midodrine, just be aware of supine hypertension, which can sometimes be very severe. You can have patients who have systolics of 240 when they're lying down.
What kind of labs do you do for the fludrocortisone, and how often?
Yeah, I just don't monitor unless I'm thinking that there's going to be an issue, to be honest. Yeah. For constipation, management of constipation in Parkinson's is unfortunately not any more sophisticated than the management of constipation outside of Parkinson's. And that's not to belittle the issue, but it's just to belittle how good we are at actually dealing with it as physicians sometimes. So hydrating, make sure the patient has an opportunity to get up and move around so that they have some sort of movement. Fiber, the usual stool softeners. Polyethylene glycol in some patients is very useful. And I know there's just this notion that there's tachyphylaxis with PEG, and you read the bottle and it says don't use it more than 7 days, but I have some patients who are on a regular dose of PEG and they're doing really well with it, so I don't see any reason not to. And as I mentioned, domperidone and physostigmine are used. I still use domperidone, especially in patients who have no pre-existing cardiac disease, who aren't on other QT prolonging agents. So you'll get a big black box warning, and you do have to maybe check their cardiogram, but it's still a useful drug. Urinary symptoms, again, look for the typical causes, especially BPH in men. But usually this is due to detrusor sphincter dyssynergy. And the problem is that the mainstay of treatments for that are anticholinergic medications, or medications that act on the cholinergic system. Mirabegron is increasingly used. The trade name for that is Myrbetriq, and I don't know if people here are familiar with that. It's expensive, but in some patients it's quite effective, and it tends to really not cause too many side effects. So when patients are really complaining of severe urinary symptoms, I have used that. Drooling, gum chewing be number one. Actually are some randomized controlled trials out there, and it seems to work, so get them to chew gum for 10 minutes 4 times a day. Sometimes increasing their dopaminergic medication can help. Sublingual atropine drops have been used quite effectively, so you just the drops that you would use, and just give them a couple drops under the tongue. And if it's extremely severe, then you can consider botulinum toxin, and again, this would be an indication MSP would pay for, but it's quite complicated, so this has to be like a really severe case before you consider going there. So pain, we want to talk about pain. So what is the cause of the patient's pain is the first question you have to ask yourself, right? Is it related to freezing, wearing off, or dystonia, as was mentioned already? And so if that's the case, if it's pain related to some fluctuation in the patient's motor state, then those principles we talked about treating their motor symptoms may actually help with the pain. So if you're getting a sense that they're describing pain every time they're off, you want to treat the off. Remember this coat hanger headache that patients get with orthostatic hypotension, so that may be an indication to treat their orthostatic hypotension if they're complaining of pain in their shoulders, and especially if they do have diagnosable orthostasis. And then more common is this central neuropathic pain, and it can be, I've heard every description of this pain in the book, really, so I don't think there's one size fits all. You can have these kind of phantom limb-like pains where patients describe that, you know, their legs feel like they're on fire. I had one poor lady who her whole sort of abdomen, pelvic region, you know, just was always feeling like it was really tense and burning, and had every investigation under the sun, and it was really determined that this was a central syndrome. So all sorts of central neuropathic pain syndromes are possible with Parkinson's disease. And the same principles that would apply to treating central neuropathic pain syndromes in any other condition, stroke, etc., would apply to Parkinson's. And that's mainly that the kinds of treatments we give for nociceptive pain don't always work really that well. So this is not a patient to run for narcotics for. You know, there will be the occasional patient in whom it's so severe that you do need to try that, but certainly that wouldn't be the first line drug. Often things like pregabalin or gabapentin will be used, and antidepressants can be used. And as with other central neuropathic pain syndromes, and again, think of phantom limb as the prototype of this, the treatment can be quite challenging, unfortunately. Some centers with specialized pain services use intravenous lidocaine infusions with success, but our pain specialists here on the island don't really have a lot of experience with that, so I don't really think that's an option here, unfortunately. So this is not for you to read, but for you to have a reference if you really are an evidence-based medicine nut about some of the treatments we've discussed today. This is a good review, again, from Tony Lang at U of T and his colleague Mary Connolly, who's a different Mary Connolly neurologist than the one who works in Vancouver. This is quite a good review paper. Couple years old now, and so there may be an updated type of review that's going to come out, but I haven't seen a better one yet so far. Okay, so very briefly, trying to put this all together. So approach to your Parkinson's patient in residential care. So please take a history when you admit the patient who has Parkinson's disease. I think everyone does that, but try to take a history and focus on some of these symptoms that we've talked about today. So when you're asking them about the Parkinson's disease, check to see whether they have, and that's the patient and the family often, because there may be some cognitive issues. Do they have inadequately controlled motor symptoms? Are they complaining of motor fluctuations? Are there psychiatric symptoms, and are there other non-motor symptoms? And going back to that list, think about, are these really symptoms that have to do with their Parkinson's? And taking an inventory of the non-motor symptoms can be useful, and that can be something that you can easily have nursing staff do. So this is a good site here, ParkinsonClinicalGuidelines.ca, and there's a little 46-page booklet on the management of non-motor symptoms of Parkinson's disease that you can download and print. It's very easy. It was made to be like a real quick reference guide to look at this carefully. And at the back of there's a symptom checklist in both English and French that you can give to patients and their families so that they can tell you about the non-motor symptoms. If there are significant problems, then trying to get a period of careful behavioral observation will often help you drill down to what the problem is. Is it a problem with fluctuation in the timing of their medications? Is the fluctuating cognitive dysfunction or the fluctuating anxiety, again, related to their medication timing, or is it not? And that will give you some clues about how to manage it. So I would say, if you can at all, fight for getting some of that observational data. It's really worth it. And that can be a fairly simple just checklist that you're going to ask staff to check off for a couple of days. So are they off or on? Do they have extra movements, yes or no? Do they have falls or gait transfers? If anxiety has been an issue, are they anxious, yes or no? So if you just make it a checklist thing for them to do and they don't feel that they have to write you an essay at the end of their shift, then very often you can get this kind of information. There was a question up here. Again, if psychiatric symptoms are the issue, then adding that to your behavioral charting is going to be important. You don't have to do this for their whole time that they're in residential care, but just getting a snapshot is going to be helpful. So it'll tell you the presence and frequency of their motor fluctuations and the relationship of those to the psychiatric symptoms to allow you to come up with a management plan. While you're collecting this information, then a good medication review is going to be essential, trying to eliminate antidopaminergic or anticholinergic medications. And if the residual problems are mainly due to motor fluctuations, then if the problem is excess dopamine, such as severe orthostatic hypotension or other autonomic features, psychosis, confusion, then again, as we said, reduce their non-dopaminergic Parkinson's medication first, then reduce dopamine agonists, then reduce levodopa, and always go slowly and constantly reassess. so that you can find that sweet spot where the patients seem to be back to some level of acceptable equilibrium. Once the medications have been decreased as low as you can, then you want to treat the somatic non-motor symptoms. So if there's concomitant dementia, consider a cholinesterase inhibitor. Treat anxiety and depression if it's clinically evident and significant. And only really treat the psychosis if it's bothersome, but if it is bothersome or dangerous, then again, go slowly and consider quetiapine or clozapine as your antipsychotics of choice. Consider reintroducing the dopaminergic medication once you've stabilized the other symptoms if you've sacrificed too much of their motor function. So if you've gotten them so that they're no longer psychotic, but they're just sitting there in their wheelchair and they can't move, then you may want to start just slowly seeing if you can get back up a little bit on their Cinemet, for example. And again, I can't stress this enough, that the most important principle is just try to make changes in small amounts, one at a time, and just frequently reassessing if you can. It's time consuming, but when it's done properly, it really leads to greatly improved function. So you can have this great plan in your head that first I'm going to do this and then that, but really implementing it in stages rather than making 3 changes at the same time will really save you down the line. All right. Any other questions or comments?
What do you do in a patient with severe dementia who have just decided that they're not going to take any more medication? They have stopped. So the question is, of course, there's nothing more you can get anymore. How would you manage the potential side effects of the withdrawal symptoms?
You would hope that that doesn't happen to be a very sudden off, you know, that they're taking 2 grams a day of levodopa and the next day they're not, because if that happens, they can get it in an MS-like situation. It can happen, and that might be a setting where you would want to introduce an NG tube. That being said, if that's kind of the decision, then you're really talking about the patient that you're really moving into palliative care with, right? And so if that's a consistent kind of behavior that's manifesting, then it's really about just orienting the goals of your care towards a more palliative approach at that point, I think. Yeah. But if it's a sudden dramatic stop from a high dose of medication to nothing, then sometimes, you know, if the family's saying you've got to do something, you may need to do something, and you may need to pop it in NG. Yeah.
No more questions. I gotta let
Okay.
you guys go for a break, but you're welcome to come down and ask him a question personally. So let's give him a round of applause.